Good afternoon. My name is Southeastern Bangladesh, Group Mappers Lead and GIS Specialist at Mahidul Oxford Tropical Medicine Research Unit, Epidemiology Department. I have been working with BORU since 2015 and providing technical support to the different disease control program here in Bangladesh. I started working with National Malaria Elimination Program at the beginning of my public health career and gradually expand my support through my team Group Mappers to rabies, dengue, soil-transmitted human disease, and COVID-19. Today, I will discuss on fine-scale mapping of malaria cases at low cost and in less time in southeastern Bangladesh using a participatory approach. Since 2017, our development of Bangladesh village-level spatial data collection methods funded through various initiatives by the Wellcome Trust, ATMEN and MORU has been instrumental in advancing malaria surveillance in Bandarban and beyond. Our primary aim was to enable the malaria surveillance system transitioning from Upazila level to village level monitoring across Bandarban district. This was enhance the precision of intervention, ensuring more efficient resource use. The project runs from July to December 2023, led by the University of Oxford, with support from local and international partners. From 2023 to 2024, malaria cases dropped from 16,567 to 11,249. With Bandarban, Khagrachuri and Rangamati contributing 91% of cases. Bandarban alone accounts for 60%, emphasizing the need for targeted efforts to achieve zero transmission by 2030 under the National Strategic Plan. In 2022, we finalized the methodology to collect village names and attributes in Lama, enabling precise identification of malaria hotspots among its 644 villages rather than just tracking cases at the sub-district level. The study focused on the southeastern region of Bangladesh, especially in Bandarban. We started by mapping villages and temporary settlements using refined Google building footprints, creating an updated village master list, updating and correcting administrative boundaries, and calculating population estimates. Collect real-time case data at the village level with trained healthcare workers. Geospatial analysis to identify malaria hotspot and fine-scale risk areas to target intervention and facilitate severe case referrals. Finally, geospatial dashboard development to visualize case data at village level in real time. In our initial phase, we downloaded building footprint from Google Open Building, which is an open source dataset by Google Research, which uses a specialized deep learning model. To ensure that we have covered the whole area, we applied graded method. Next, we overlay this data with Google Images, filling in any missing settlements to ensure comprehensive coverage, all done at our desk. In just 18 days, we deployed a team of 12 people to map 6 upazilas, resulting in more than 577,000 building footprint. Among them, more than 312,000 footprints were adjusted, and we created 6,232 grids to ensure comprehensive coverage. This massive amount of data gives us a successful foundation to work with. Following this, we sent team to the field. Initially, they collected existing list of villages from multiple sources such as BRAC, BBS, local administrative authority at the ward level. Then the team merged the list. This list undergoes verification by the stakeholders. We then group villages into villages and then group buildings and naming the next villages. Working through one union at a time, the village centroid were determined and administrative unit boundaries were updated as needed. This whole process typically takes 7 to 10 days per sub-district. We created 20 maps covering 4 upazilas, including 1,347 paras and 82 camps In just 32 days, we deployed a team of 4 people to map these 4 upazilas. We believe this information can be instrumental in providing intervention to these communities, contributing to our efforts to achieve the last mile of malaria elimination. We gathered crucial geolocation data covering administrative units at various levels down to the village level, along with different type of camps and construction sites. Additionally, we acquired information on ethnic groups for each para mohalla camp, assess mobile network accessibility and count population for each village. Let's talk about some results. We successfully mapped 8,500 grids, each covering 1 square kilometer, adjusted the location of more than 312,000 buildings, and surveyed an area of 7,832 square kilometers. During this process, we identified 2,009 paras and mohallas and 99 camps, including 1,036 tribal paras, 846 Bengali paras, and 127 mixed paras. Additionally, 1,526 paras and mohallas camps were found to have access to mobile network. The maps reveal key insights into Bandarbhan district's demographics and accessibility. Population density cluster in Bandarbhan Shodor and Lama further stress the importance of prioritizing accessible infrastructure. Of 2,108 villages, 72.4% have mobile network access, while 27.6% lack it, highlighting disparities in communication infrastructure. Ethnicity: 834 villages are Bengali, mainly in urban areas, and 974 tribal villages are in rural, hard-to-reach areas. Additionally, 127 mixed ethnicity and 50 tribal community villages underscore the need for equitable service delivery. We have updated the administrative boundaries for 252 wards, 28 unions, and 5 upazilas by incorporating the collected geolocation of para mohalla camp areas to align with the existing administrative boundaries of Bangladesh. However, when comparing the map, it becomes evident that there are significant discrepancies between our updated boundaries and the existing ones across various administrative levels. We compared population data from building footprint, household size surveys, and the Bangladesh Bureau of Statistics. For example, in Naikinchuri Upazila, population estimates aligned with survey data, but showed a significant discrepancies when compared to Bangladesh Bureau of Statistics figures. In January, we updated village maps and trained 441 health workers in Lama to report real-time malaria data. Challenges included language barrier and limitation in the data platform exist. To address this, we had started a training of trainers approach, training supervisors to mentor grassroots workers with ongoing monitoring of their sessions. This analysis highlights the malaria situation in 2023, with 319 out of 665 villages reporting malaria cases, representing 48% of the total villages. The affected population stands at 78,232, with 70% having access to mobile networks. Most malaria cases are concentrated in 4 unions: Gajalia, Lama Shodor, Rupushipara, and Shoroi, where over 85% of the cases were recorded. The spatial distribution of annual parasite incidence shows hotspot for Plasmodium falciparum and Plasmodium vivax, enabling targeted intervention to reduce transmission in the most affected areas. This analysis uses geospatial method to identify malaria hotspot and cold spot across villages in 2023. The result shows 101 villages classified as hotspot for overall malaria, 71 for Plasmodium falciparum and 108 for Plasmodium vivax at 90 to 99% confidence interval. In contrast, 283 villages were identified at cold spot for overall malaria, with 153 and 302 cold spot for Plasmodium falciparum and for Plasmodium vivax, respectively. Physical accessibility modeling reduced significant travel time disparities to health facilities, impacting malaria control and healthcare access, while villages in Alikodam and Rukushibara are within an hour facility, areas like Ruma and Kanchi faces over 3 hours of travel. The box plot shows travel time viability, and the bar chart highlights accessibility gaps across different categories. We developed the geospatial dashboard Malaria 360 as a surveillance tool that includes the malaria API tracker and community malaria tracker. The malaria API tracker visualizes Upajila level data from the malaria information system through an application program interface, enabling seamless data integration and analysis. Meanwhile, the community malaria tracker focuses on village level data, utilizing an SMS-based data transmission system and digital forms to facilitate real-time data collection and visualization at the community level. We have a great team with national and international professionals along with volunteers. We are active in all social media listed here, and anyone can donate through Oxford Development Office site. I extended my sincere gratitude to all the funders, including the Wellcome Trust, ATMET, and the National Malaria Elimination Program, as well as the local government authorities. A special thanks to all our volunteers across the country for their wholehearted support. This is end of my presentation. Thank you for patience here.